In the Doctor's Office, Recovery Friend or Foe, will be presented by Matt Statman and Dr. Mark Weiner. Dr. Mark Weiner is the Section Chief of Addiction Medicine and the Medical Director of Substance Use Disorders at St. Joe's in Ann Arbor. He is also the Medical Director of IHA Pain Management Consultants. He is the Chair of the Planning Committee of the American Society of Addiction Medicine and is a member of the Planning Committee for the American Society of Addiction Medicine annual meeting. He is an editor of the upcoming ASAM Pain and Addiction Handbook. Dr. Weiner is also the chair of the Board of Trustees of Don Farm. Matt Statman is the manager of the U of M Collegiate Recovery Program and the faculty advisor for the U of M Students for Recovery. He is an adjunct lecturer at EMU's School of Social Work and a board member of the Associates of Recovery in Higher Education. Matt worked with Don Farm from 2004 through 2012 in various capacities, including residential therapist and education series coordinator. Last July, Matt received the Kitty L. Harris Lifetime Achievement Award from the Association of Recovery in Higher Education. Please join me in welcoming Matt and Mark.
All right, hello everyone. Thank you for coming out tonight. Thanks to Don Farm for having us out here again. So tonight we're going to talk about how to be safe in the doctor's office for people in recovery. And what I'm going to do is kind of just set the table, and then Mark is going to bring you your meal. And then we'll have Q&A for dessert. I am not conflicted about my interests, and I have a lot of biases, some of which you might hear tonight. Feel free to disagree with me. But I think this is an important talk for people in recovery. It's definitely something that a lot of the stuff that we're going to cover tonight was important to me in early recovery to become aware of, and it has continued to be important to me throughout the years that I've maintained my recovery. Everybody ends up in the doctor's office. Everybody should end up in the doctor's office, and it's important to be educated about what issues you might face when you're there, or how to have your doctor be an ally in your recovery as opposed to a person who might help you end your life. People in recovery should be in my opinion, people in recovery should be very suspicious of people who are in the medical profession. I have a lot of friends who are in the healthcare world and a lot of friends who are doctors. I love them. I think there are a lot of good doctors. I think there are also a lot of doctors who don't know what they're talking about and don't really know how to treat people who have addiction or who are in recovery. And so we need to become our own advocates. And we need to be careful because it's really easy to slip. Our culture is pain averse, right? We don't like feelings and we don't like pain, and we have been normed to pop pills in avoidance of that pain. And whether you're a person with addiction or not, that's sort of the world that we live in. That's what our healthcare system is trained to do. And so we like instant relief. And for people in recovery, instant relief is often not realistic or unhealthy. Our medical system, I think, is geared often toward sort of symptom relief rather than looking for what's underlying it. And in the case of pain, this was something I heard on NPR a couple of years ago before we did this talk, and this doctor-to-be was visiting Cuba to look at their healthcare system, and he was kind of blown away that they were looking at not as pain as a symptom in Cuba. And I sort of felt like, wow, that's how they should be looking at it. Maybe we are doing things backwards here. Not that people should be suffering, but we should be looking at the root causes of that kind of stuff. And so we prescribe a lot of pills in this country. If you haven't heard about this opiate thing we have going on, you're probably willfully not paying attention. There was a pretty incredible thing on 60 Minutes a couple weeks ago that I would suggest checking out about the DEA and the pharmaceutical industry and the stories about that. We could do hours on that stuff. But we got a lot of pills going around. This was a slide from a couple years ago on MLive, and we have more opiates being prescribed in the state of Michigan than we have people, right? So there are, a few years ago, there were 75 opiates being prescribed then for every man, woman, and child in the state of Michigan. And I'm sure that number hasn't gone down much since then. Lots of pills. Most doctors don't know about addiction. Studies show that doctors haven't received adequate education when it comes to this. I think there's a growing awareness in the medical field that this is some important stuff. And my first slide showed, talked about a little bit about how we're moving addiction treatment into the mental health care into a more medical. We're sort of integrating services, and so it's important that they know about this stuff. I was actually working with a person in recovery today who needed to see a psychiatrist because she's taking fewer of her psych meds than she should be, and she didn't talk to a doctor before she started tapering her dose. And I wanted to help her get an appointment with a psychiatrist where I work, and they said, well, she needs to, before she can see a psychiatrist, she needs to go through a primary care doctor. And I'm thinking, what the heck is this primary care doctor going to know about this person who has co-occurring mental health and substance use disorders? It's highly unlikely that they're going to be able to give her the kind of care that she really deserves, And maybe there are some doctors who are trained in that, but from what I've known and from what I've seen, it's not the norm. And the last bullet point here talks about how a lot of doctors mistake physiological dependence with addiction. And I think Mark is probably going to talk a little bit about how those two things can coexist, but they're not synonymous. Here's a couple more stats. 3 to 12 hours of training for 56% of in 56% of residencies, and SUD was on, substance use disorders were on 0 to 2% of the exams. So it's really just inadequate. I mean, if on the low end 10% of our population has addiction, and on the high end, 30% have or more have substance use disorders, then this training is woefully inadequate. A lot of studies show that physicians can't adequately screen or diagnose for substance use disorders, and they don't know what to do with people once they figure out that they might have a substance use disorder. They don't know how to do screenings, and they don't know where to refer to. And I regularly help doctors figure this kind of stuff out. Sometimes physicians call me and say, hey, we got this person down here and X, Y, and Z is happening. What should we do next? And just because they know that I worked in the treatment world, they come to me asking these questions, which is good. I don't think most doctors are humble enough to ask or even know who to ask if they wanted to. Am I beating up on doctors really bad right now? I love doctors. So here's just some more stuff. People are, again, undertrained. And this is, I think, even more pertinent for people who are in recovery. Doctors, I've told my doctor I am in recovery. When I go to a new doctor, it's one of the first things I say. I'm in recovery, and that means this, and don't prescribe me this unless I'm like dying. And and when I've gone to a pain clinic before where for some back issues, and when I fill out the forms, it says, what are you allergic to? I write down benzos, opiates, sedatives, stimulants, anything that affects me from the neck up, I'm allergic to. And it doesn't mean I never will be in a position where those will be medications that I will have to take. I hope I'm not, but most people probably are. But I want them to be very aware. And even though they are very aware, I am frequently offered those kinds of medications multiple times, even after refusing them multiple times, in all different kinds of healthcare settings. So they might know I'm in recovery. They might have read my intake form. We might have had a conversation about what that means. But then 6 months later, they might say, you can try some Ambien next time you travel. And let me just write you a prescription for it just in case, right? Which happened to me last time I traveled with a doctor who I had this conversation with. And this one's about overdose, but doctors can learn. And when presented with alternatives, they often will use them. They're not out to hurt people or to make people relapse. They just often lack a formal education in how to deal with people in recovery or how to help prevent addiction or work with people who have addiction. So it's a matter of education in a lot of doctors' case. So the time is now, and I think it's improving. I think we are having. I mean, I hear this conversation happening out there in the world a lot more than I did a few years ago. I think the crisis that people are seeing now in privileged communities around opiate deaths has caused a different kind of conversation to happen, and that is one positive that might come out of this whole thing. So doctors, I mentioned this, doctors often don't know enough about recovery. If you're a person in recovery and you're experiencing a series of symptoms like this and you go into your doctor's office, he or she might say, how have you been using? When's the last time you used? They're probably not going to ask you how your recovery's going. They might not even know what that means, right? I mean, to a lot of doctors, abstinence equals recovery. And what we know is that's not true, right? Abstinence does not equal recovery. In fact, for someone who has addiction and they are trying to be abstinent without doing anything behaviorally different to put them in recovery, they will often have symptoms that look a lot like various mental health disorders or physical health problems. They'll be restless, irritable, and discontent, right? That's what happens to a lot of us if we stop doing recovery and we're white-knuckling abstinence, right? And for a doctor who doesn't know about recovery, they're going to take out the prescription pad instead of telling you to call your sponsor, right? Or go to more meetings or go to therapy. And that can be dangerous. So doctors need to learn more about recovery. And I think as a person in recovery, it becomes my job to help educate my doctor. Because recovery is lifestyle medicine. I just pulled these off. And I think the next week or in a couple weeks, Jerry's going to talk about personal medicine, and that probably fits in really well with this. But it's the idea that for chronic illnesses, behavioral interventions are often more effective than medications, although they don't work like that. I mean, we all want a quick fix. But changing lifestyle is what we do in recovery, and recovery maintenance involves a bunch of lifestyle changes and choices that we make on a regular basis to sustain our recovery. And when we stop doing that, our symptoms come back, right? We become restless, irritable, and discontent, and eventually at the end of that is a drink or a drug. The other thing is that doctors are often marketed various medications that are supposedly safe, right? And so Ultram was supposedly a non-addictive, non-opioid thing that was safer than the other drugs, and we found out that that's not true. A lot of people's relapse starts with Ultram. At one point, Quaaludes were marketed as less harmful than barbiturates. You know, if you're old enough to know what a Quaalude is, you probably never took enough of them. OxyContin was, you know, safer too, according to the drug companies, and we all know where that ended up. And now gabapentin is one that's been prescribed. I think it's prescribed for like 99 problems, and now we're seeing people, you know, it's both something that people misuse, and it's also something that can start the path back to addiction for a lot of people. It's also a helpful drug for some people, and you know, there's a place for all of this stuff. I don't know about Quaaludes, but there's a place for a lot of this stuff, you know, when used properly under the right conditions. But people who are in recovery need to be really extra wary about this stuff, you know. So when we talk about like dangerous, high-risk situations in recovery, we often think about things like divorce, loss, grief, moving, family situations, the anxiety and angst that comes with waking up in the morning. But we don't often, or often enough, talk about the pharmacy, right? And we've talked a little bit about what happens behind the pharmacy with all those prescription medications. But there are a lot of over-the-counter medications that people in recovery need to watch out for too. And Mark's going to go into more detail about this, so I'm just going to kind of skip over it. But you can, if you're in recovery, it's a really bad idea to walk, if you're sick, or you can't sleep or whatever, it's a really bad idea to walk into the pharmacy and just grab something off the shelf because other people use it and it works for them. You really got to educate yourself about what kinds of medications can be a threat to your sobriety. And this is this is a very short list. This medication guide is one that I use often, and you can just Google it, Talbot Medication Guide, and they have it's for people in recovery. And they have a whole list of all the over-the-counters and all the prescription meds and what is sort of in the safe range and what is in the range, and then what you should probably avoid unless you're in an emergency situation. The other thing to think about is what will happen in an emergency. When I'm already in pain, I make bad decisions, right? And so for a person in recovery, think about and plan ahead for what you might do in an emergency situation. Because at those times, when you just want relief, one bad decision can send you down the wrong path. And I've been there. I've been in the emergency room in recovery and had already thought about previously, okay, this is what I'm going to say, this is what I'm going to do, this is where I'm going to draw the line. I've talked to people on the way to the hospital who are in recovery and had people meet me there, that kind of thing. If, you know, I mean, if you're in an ambulance and you're unconscious, you've got no control over that. But, and then what do you do if you are administered medications that are contraindicated for people in recovery unless it's an emergency? How do you handle that moving forward is really important too, you know. And I've heard people say, well, you got to go to more meetings, you got to call your sponsor more, you got to talk about it, blah, 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 blah. But you plan for that stuff because in the moment, it's often, you're not thinking clearly about how to deal with that stuff. So the doctor's office can be a dangerous place, and primary care is also important. A doctor can actually be an ally in our recovery if we can help them help us. In terms of chronic illness management, addiction, for most of us who have addiction, it's a chronic disease that's not going away. We learn how to manage it through behaviors and sometimes with medication, but it's not going away. And we don't think of addiction as a chronic illness in our society. We think we can send someone off to Malibu for a couple weeks and they're going to live happily ever after with the addiction cure, and they're never going to have to think about it again. Or they're just going to grow out of it like, you know, like someone else we know did. Or now that you've been sober for a couple years, you can stop going to those classes and just have wine with the family. Like, we don't think of addiction as this chronic issue that it is for a lot of people. And treatment for addiction works just as well as it does for other chronic illnesses. With hypertension, when people have hypertension and they engage in treatment, their symptoms go down. When they stop doing their treatment, whether it's behavioral or medical, their symptoms come back. The exact same is true for alcoholism. When people go into treatment, their symptoms are really high. Then they get into treatment, they start doing the things that they need to do to stay healthy, their symptoms go down. They stop doing those things, and their symptoms come right back, right? So same thing, it's a chronic illness. It behaves just like other chronic illnesses with and without treatment. And so here are some slides that show sort of what medication, what compliance with treatment is and what the relapse rates are. And it's pretty much the same for almost all chronic illnesses. It's in the same range. So people don't comply with their treatment plan very well when they have chronic illnesses. Most of the time the deal is you go into treatment for an illness, you are willing to do whatever you need to do to feel better, you start doing the things that make you feel better, and then one of the first things you stop doing when your life comes back and you get a good life is you stop doing the things that you needed to do to stay well, and then your symptoms come back, then you relapse. And that's the same with all chronic illnesses. So, but you know, we have models of care that treat addiction like chronic illnesses, and when we treat addiction like a chronic illness, people get well, even doctors. The physician healthcare programs are a model that many of you have probably heard of. Some of you probably haven't. Some of you have probably been involved with one personally. But if you want to find out the best way to treat any disease, find out how doctors treat other doctors who have that disease. And how do doctors treat doctors who have addiction? They don't send them to some place in California with a buffet for 2 weeks and then just give them their prescription pad back. It doesn't work. They have physician healthcare programs, which are the standard of care for abstinence-based treatment, and they work really well. And doctors who run into problems with addiction and who are part of physician healthcare programs, they also have these programs for lawyers and for airplane pilots. They get care management for 5 years, right? So people who have chronic illnesses, the longer that they stay engaged with a treatment system, the better outcomes are. With PHPs, it's 5 years. They get treatment, they get the level of care that they require. So when they're assessed and the assessment says this person needs 6 months or 90 days of residential treatment, they actually get to go to 6 months or 90 days of residential treatment. They don't necessarily have to go somewhere that's inadequate for them and fail in order to get a higher level of care. They get monitored intensively, not because they want to punish them if they have a recurrence of symptoms, but because they want to be able to re-intervene and help them get restabilized as quickly as possible before they burn everything to the ground. And they're engaged with sober social support, including the 12-step community. So the social piece is really important. Most people don't have access to this kind of care. So we, as in society, we sort of say treatment doesn't work when we have a model that works, but we don't. It's more complicated than what we're willing to invest in, and so we don't. We'd rather just write a prescription and send people on their way, or give them a couple of weeks of treatment and see them again in 6 months. And there are lots of reasons that there are lots of excuses that people give for why we don't try to give this kind of care to everyone else. One of them is that doctors are just different. They probably are, but not in the ways that people think they are. They have they have more recovery capital, right? They have more to lose. They have more internal resources, that kind of thing. Nobody who has addiction, once they've been addicted for a period of time, nobody wants to be addicted anymore. People want to get well. And so, so it might be more complicated to treat some people than others. But what doctors' brains aren't any less addicted than anybody else's, and they get well at really high rates when given this kind of care. So it's a social justice issue. If we know that people who have severe addiction problems, doctors often have severe addiction problems, if we know they can get better given the right kind of care, and we're not giving other people that kind of care, we're not even trying to give other people that kind of care, and maybe some people have a more complicated set of issues, don't they deserve the opportunity to get well in the same way that people who have good jobs do, you know? Because they're not hopeless. Dawn Farm has tried to model this. They will, you know, they have a pretty long continuum of services. You can go to Sparrow, which is like a detox. You can be there for a few weeks now. You can then go to the farm for 3 months and then go to transitional for a couple of years after that. So hypothetically, someone could be involved with, and then you could be an outpatient after that if you wanted to, but hypothetically, Dawn Farm can keep people engaged with with recovery management for a couple of years. And they're introducing you to the recovery community, which is free and it's everywhere, and you can manage your own illness that way. Collegiate recovery, where I work, is another model of care that a lot of privileged kids get. I can work with students who are in recovery the whole time they're in school. Sometimes that's more than 4, 5, 6 years. They can come meet with me as much as they want. They can come to groups as much as they want. And our University of Michigan students can even come see me after they graduate, and some of them do, for as long as they want. So there are, and they stay sober at really high rates in collegiate recovery. There's not a ton of research about collegiate recovery yet, but the early research over the last few years shows that the programs around the country have students who are staying sober at incredibly high rates. People wouldn't think that people who have addiction could stay sober at rates so high, but it's just because we don't really try to have services that meet people where they're at and keep them engaged for long periods of time. So it's important to make your doctor an ally. In order to prevent medication-related relapse, to have a pain plan, and for recovery-informed care, because your doctor can be a person who you see once or twice a year and who does check in with you and say, how's it going with your recovery? Are you doing the kinds of things that you told me that you do to stay healthy and well when we first met? And if so, if not, why not? You know, and do you need any help from me as your doctor in order to get back on track with those things? Because I know that you told me when you first saw me that that when you stop doing those things, you become symptomatic again, right? So a doctor can be an ally if you ask and if they're trained to, know how to support people in recovery. And they can help you, get back into treatment if you need it, if you happen to relapse. So for people in recovery, there are doctors who know about this stuff. I would say talk to other people in recovery who have been sober for a while about who the good doctors are in the community. Ask your doc about what they know about recovery, if they've ever worked with people who are in recovery, if they've treated people who are in recovery. Be very assertive about those meds. Like I said, I've had to talk to my providers multiple times about this stuff. And plan ahead for emergencies. And that's all I got. I'm going to pass it on to Mark.
Thank you, Matt, and thanks for the introduction earlier. Again, in case you forgot through Matt's long presentation, my name is Mark Weiner, and I do addiction medicine. And I'm a doctor, and I've decided to dispense with the slides entirely and just make fun of therapists for the next 30 minutes, because I think it's fair. Now, I have to say, Matt was right. Doctors are part of the problem. Education is really poor, but it's part of a bigger problem in my view. That's the entire healthcare delivery system and society as a whole that, stigmatizes addiction, fails to identify it, and devote appropriate resources to treat it. But this particular topic about the doctor's office being sort of the entry point for a potential relapse is a very important one. And Matt and I know many people personally. I know I've run into patients professionally who have had a relapse as a result of going to the doctor's office, and many people who have died as a result of that relapse. And I don't think the doctor was intending that to happen. It was just a lack of education. So you guys are going to learn tonight more about addiction than the average doctor knows. So you can take that to the doctor next time you go. I have no conflict of interest that I can think of. I'm open to conflicts of interest. If you have a lot of money and you have a conflict, run it by me. We'll see if we can come up to an agreement. But I don't take any money from pharmaceutical companies or anything like that. So the objectives of my part of the talk are to learn a little bit how drugs act on the brain of an addicted person. Without that knowledge is very important because, again, the doctor is not intentionally starting a relapse for a person in early recovery or in even long-term recovery for that matter. They are just exposing the person with good intentions often to a substance that starts the addictive process. And I think it's important to know how that process is started to understand why these substances can be dangerous. In order to understand that, I'm going to give you a very basic understanding of how the brain works when it comes to addiction. And just so you know, because I've had questions about this, the neurobiology of addiction is probably just one part of the whole addiction process. There are probably lots of other things. There's psychological issues, early life trauma, who knows what, a lot of genetics involved. This is part of what we now know about how a certain part of the brain works when activated by addiction. At the end, it'd be nice if the person in recovery feels more comfortable about telling the doctor that they're in recovery. And just as a show of hands, who is in recovery here? Okay, and keep your hands up. Who has a loved one, friend, or family member who's in recovery or struggling with addiction? Okay, nearly 100%. Okay, good. Should all like this talk. We're also going to discuss issues regarding pain, insomnia, anxiety, and depression in addiction because these feelings, these symptoms, come up frequently, almost universally in people in early recovery. And the way those are approached by the medical profession could be dangerous, so I'm going to provide you with some knowledge about how they might be handled in a more healthy way. And we hopefully will have lots of time for question and answers, and my estimation is you'll have 30 seconds at the end. Yeah. Okay, so the basics of neurobiology is that the brain, the human brain, has a pleasure center or a reward center that is activated by a number of things, positive rewards that occur that keep us alive in terms of food when we're hungry. It drives us to procreate. It drives us to find shelter. But it is a system that can be hijacked by chemicals. When this system is activated, it is involved in the way to look at the way the brain works in something called salience, which is how the brain determines what is important in the world. it changes that. So, and we'll talk about some examples, in a few minutes, but if you're telling the brain what is important or forcing it to think about what's important in a certain way, you are really driving the behavior of that person or animal, because they're going to keep wanting to do what's important or what feels good. So it's when this center is activated, we know because of the way the nerve fibers go to different parts of the brain, that when the addiction center is activated, it modulates. It means it changes, it alters memory, emotions, motivation, and, my favorite, logic. So logic can be altered by this part of the brain kind of being hijacked or being used in a healthy way, and we'll talk about that. Once addiction activates that center, it appears that that center and the way the brain processes things may be permanently altered. Or, if you don't believe that, it could be that the genetics are such that once this process is in place, it's really hard to unwire it. We know that when someone is in recovery and they are simply exposed to chemicals, it's not a 100% chance, but a very, very high chance that it'll activate their addiction. So again, what is salience? Salience is this thing just to think about. It's, again, a term that just means what the brain and what the person thinks is important, and it's what is remembered and what is meaningful. So an example, which we'll talk about, well, I'm going to skip that and talk about it later, but for instance, an animal who finds a ripe piece of fruit and it tastes good, that suddenly becomes very important. It drops their drive for hunger and they feel good and they remember that. And we do. We're sort of advanced animals in a way. So in order to understand the neurobiology of addiction, for a few minutes, just memorize this slide, because it'll be very helpful. Actually, this is referred to as a dumbed-down version of the rat brain and the addiction center, and I had to memorize every part of that slide for my board's exam for addiction medicine. But I'm going to make this really simple. Okay. So the pleasure circuit, which occurs in every person, healthy, addicted or not, is made up of a couple of important components. One of them is called the ventral tegmental area. You do not have to remember that. And the center is called the nucleus accumbens, which is the center of this circuit. The purpose of the ventral tegmental area is to activate through specific neurons an increase in the amount of dopamine around the nucleus accumbens when something happens. And when the nucleus accumbens senses this extra dopamine, it tells you everything's okay. It tells you what just happened was good, okay? Now we'll be a little specific in the example. So this is, again, the monkey going through the forest who's really hungry, doesn't know where food is because he's really young, and he sees a banana up in the tree. Now, he doesn't know much about bananas yet, doesn't know much about climbing, but the whole process is very scary. He eventually climbs up this high tree, banana tree, and he eats the banana. He feels better. His brain says, you just did something good. And then various parts of the brain are now modulated. Now, that experience for that particular, for that monkey was very varied in terms of it was a very scary thing to go up that tree, which in certain ways would make him not want to do that again. But because this was a good experience and connected with survival, that sort of negative emotion was turned down. So he doesn't feel scared. He doesn't think of it as being scared. The experience of how good it felt to go from being hungry to not hungry was really important, so the good feeling was turned up. Logically, this monkey now will start figuring out how to find bananas when he's hungry. That will be a solidified connection. The emotion about finding the banana when he's hungry will be good. The memory of where that tree was, what the banana looked like, what the sky was like, everything about that scene will be committed to memory, very important for survival. And the ventral pallidum, which motivates the monkey to do something again, is going to motivate the monkey to do this next time that there's an issue. This is very powerful. We all have this, and this is what helps us to be, survive in our environment. Very powerful thing. So imagine if it's hijacked. So we know that certain drugs can directly influence that dopamine around the nucleus accumbens. That's the feel-good substance. Now, before you think about it, start the drug addicts out there thinking, well, if I eat enough dopamine, how am I going to feel better? It doesn't work that way. Dopamine would make you very sick. But just the level of dopamine in very minute areas around the center of the brain causes that feeling. But these drugs produce an activity that is far beyond what the normal brain is supposed to experience in terms of dopamine. It is unnatural. It is supernatural. And the dopamine is beyond what the brain has ever experienced. And the brain goes nuts. Now, this is what happens to the human being who is exposed to crack cocaine the first time, or opiates the first time, or alcohol the first time, or cannabis, whatever works for that particular individual. There's this, and some drugs are different for different people, but eventually you get to a process where the brain is now hijacked. It just found something so good that it supplants all the other good things in that person's life. And when you look at the behaviors of people who have addiction activated, you think that it may seem that they're crazy, or they're bad people, or they're immoral. But what's really happening is that their priorities have been rearranged by exposure to a substance. It's a very, very powerful thing. And so when the person gets the crack cocaine for the first time, he thinks this is great, or he or she, and their emotions say it's wonderful. The memory of the fear and what happened to get that drug is reduced, so it doesn't seem like it's a bad idea to do it again. And the ventral pallidum will motivate that person to do it again. And it explains why you can see people in their addiction doing things that are incredibly dangerous, potentially harmful to themselves and to the ones that they love. And people will put their children in situations that are scary, things that they would never do in recovery while thinking clearly, because this is activated. Does that make sense to people? Okay. It is a way to explain something. Now you'd think if you were smart and you knew this, and somebody was in recovery, you therefore would never, under any circumstance, expose them to a drug that would destabilize their recovery, right? This is what most healthcare professionals do not know. This is not taught in medical school. Now, the pleasure circuit also, it feels abnormal once that drug is removed, because the dopamine level was so high, perhaps, or things have, the normal level has been reset, so the person doesn't feel right, and often this drives them to use again if they're not met with good recovery resources. Exposure to drugs can certainly cause relapse to occur, but some of the things that Matt was talking about in terms of the environment and things that set off the potential for relapse have been explained at the neurobiological level. We know that there are fibers that actually go the other direction from the memory centers back to the nucleus accumbens, so that memories can start priming the pump to start the person in active addiction. So that would be what? What do we call that? People go to AA. People, places, and things. You got to stay away from things that were related to or were cues, triggers to using again, right? We have to avoid those things. Also, stress. There's another group of neurons that goes from the amygdala in the setting of stress. It's mediated by glutamate, another neurotransmitter, and that can prime the pump as well. That's why a lot of people relapse in periods of stress. In fact, most people I've treated has anyone here ever quit smoking at any one point in their life? Okay. Has anyone quit smoking and then smoked again? Okay, right. So what was the thing you think about that started you smoking that time? What if you describe your life at that point? What was it? Kids. Okay, kids, no. Yeah, kids are stressful, I'll tell you. But it's usually, most people report some level of stress being what occurred just prior. Not all the time, but it's very common. So stress is a very powerful modulator to push someone a little more toward relapse. And of course, stress occurs in most people when they're not feeling well. So not feeling well, going to the doctor's office, you already have the odds stacked against you. So again, the exposure to the substance creates this abnormal level of salience where that experience is so powerful that it becomes as important or more important than oxygen to that person. And they would be willing to do anything to feel that way again. And they don't know that that's what they're doing. Because remember, the addiction can modulate the memory and logic center, so the person engaged in that doesn't notice what's going on in the same way that we would as an outside observer. So are prescription drugs potentially a problem? I think I made it clear right there, yeah. They're a problem because they are the drugs that people get on the street, like heroin and cocaine, which are opiates and stimulants, can be provided in a doctor's office in the form of Norco and oxycodone and Adderall. And so these things are still present. They just seem to be a little bit more acceptable when they come from a doctor's office. But to the person's brain who has addiction, they are exactly the same. This is a problem just showing the exposure to people 12 and older. Their first experience with drugs is often a prescription medication, and its use as a first drug has skyrocketed since about the early 90s. And that's also about the time that sort of the medical profession became much more open to or happy about prescribing opiates to people. It's where sort of the drug companies started their marketing to get patients back on opiates for chronic pain issues. And there was much more opiates available in your local family medicine cabinet. Sometimes we get a clear sign of where the problem is. Sometimes it's not so clear. That's a subtle joke for those who read. No. Okay. So Matt started talking about what do you do? What's the process then for if you're in recovery? And I guess I've had this question too, like what is if it's your loved one who's in recovery and you're there at the doctor's visit, can you say something? And I think in my opinion the answer is yeah, anything that could help save that person is worth it, but you better kind of talk it out before you get there just to see what kind of result you're going to get. It's important though to tell the doctor early, as Matt was talking about in his experience, right off the bat, say, I'm in recovery. I do not want to be exposed to drugs that are potentially addictive. And this last sentence, I think it's a passive-aggressive statement on my part, but to say to the doctor, do you know enough about addiction to keep me safe? Because the answer usually probably is, if they're being honest, is no. But some doctors do, and you might find one. And finding a doctor who knows a lot about addiction is pretty difficult, I think, statistically. The doctors who know, I think, the most about addiction are those who are board certified by the American Society of Addiction Medicine, which are like me, or addiction psychiatrists who have a similar study of addiction. But for the most part, unless a doctor has decided to take up a special training on their own to learn about it, they just don't know. And they're scared too because they don't know. So it's important to repeat yourself frequently and remind your doctor at every visit and with every medication perhaps that you're in recovery and is this safe. But just to be clear, because this sets up this kind of thought here as well, did you just say that as a person in recovery, I should be denied treatment? And the answer is no. You should not be denied treatment at all. It's actually the opposite. Because to be clear, I tell other doctors that a person in recovery who's in untreated pain, that is an unstable situation. That person definitely needs some sort of treatment. But they deserve the same level of care, just a different group of medications and a different set of risk stratification than you would in somebody who doesn't have addictive illness. So again, ignoring the symptoms causes an unstable situation, increases the risk of relapse. I think because of what we're learning about drugs like opiates and benzodiazepines, that if a person in addiction gets care that excludes those, they are getting better care than the person who is getting those medications. In fact, the way the world looks at a lot of things, if you look at most industrialized and some of the best healthcare systems in the world, patients are not being prescribed benzodiazepines, which are Valium and Xanax and Ativan, Klonopin. They're not getting those because studies show that they make symptoms worse over time and cause a whole lot of downstream problems, and very few of them are getting opiates for their symptoms. But our culture is also different here, where the expectation of both the doctor and the patient is that there'll be a pill coming before the end of the visit that's going to fix the problem. And that's something we have to kind of uproot and change. It'll take a lot of work before we get there. So people in recovery go to the doctor for the same reasons that people who aren't in recovery go to the doctor. Pain is the #1 reason that people go to the doctor in general. Sleep problems, concentration problems, depression, anxiety, colds and flus. These occur in most people. The sleep problems, concentration problems, depression, anxiety, I think are much more highly represented in the person in early recovery, because that's just kind of a natural way that people feel when they start dealing with life without their substance. And Matt alluded to this too. Who thinks the term non-narcotic means safe? Well, I'm telling you there it doesn't. But it's not, and it's a common misunderstanding. I have patients in recovery to this day walk in and say, well, I want something non-narcotic. And so you didn't really say anything, really, because certain narcotics are dangerous to people in recovery. Narcotic is simply a legal term. It means something that the government, who we all trust implicitly, 100%, to never make a mistake, has said that this particular substance is potentially habit-forming or can cause a dependency, and therefore this would be in a controlled group. Now, believe it or not, mistakes are made. And some common ones here, tramadol definitely is not something that is safe. It is a pure opiate. It works just like opiates in the human body. Why it's not controlled or hadn't been controlled for a long time is a mystery to me. Everyone heard of the drug Soma? Soma is what? Everyone says muscle relaxer, right? Muscle relaxer, by the way, is a marketing term. There is no substance that relaxes muscles. They all relax the brain. And so Soma, or carisoprodol, is a drug that works just like a sedative. It's converted to a sedative. It has not been controlled for a long time. I don't think it's still controlled now. It causes the same problems as Xanax or Valium, in a person who's in recovery. So take-home point, non-narcotic does not mean non-addictive and doesn't mean that it's safe. So I think you guys know all these things. These are the problematic medications, or if you're in recovery, these used to be some of my favorite things, opiates and sedatives and dissociatives. If you take enough Robitussin, that's a problem. That's one of the more common drugs of abuse right now. Steroids can be problematic. Even prednisone can cause an effect in some people that makes them feel strange, but also makes that strangeness something that they want to keep doing, and they don't want to come off prednisone. Stimulants, you can get in the doctor's office, Adderall, Concerta, Ritalin. These are all amphetamines that are seemingly okay, basically only in the United States. It's not okay in other parts of the world as treatment for just about anything. And a lot of medications contain alcohol. NyQuil is 50 proof, just in case you needed to know. Of course, if you like a lighter drink, you can drink some Listerine or Scope, which patients do. And you're getting a big bang for your buck compared to beer, wine, or brandy. And herbal and natural doesn't necessarily mean safe either. And I could give a whole talk on just this, but certain drugs, opium is natural, cocaine is natural, cannabis is natural. These are herbs, right? These have to be great. Everyone should be on, we're not going to go there tonight on everything with marijuana. But common valerian root in some people works like Valium in some people and becomes very difficult to stop because people have a withdrawal symptom. Kava kava, kombucha, anything that is designed or says will make you sleepy, awake, changes your mood or energy level is a suspect, is a potential problem. 5-hour energy shots, good idea? I don't think so. I'm not doing them. But are they a problem for everybody? Clearly no. Monsters, they must be great because everybody at the meetings are drinking them. So, but I think they should be suspect as potential problems for somebody who's trying to live chemically free. Okay, a little bit about pain. This is probably the hardest thing to get into somebody's head when they're especially an opiate addict in recovery, because they feel that the best pain medicines are the opiates. And we're keeping the best pain medicine from the person who needs pain treatment. And I will tell you that opiates are not great pain medicines, especially for people with chronic pain, and especially for people who have had opiate dependency, because they just don't work the way we think they're going to work. Now, why do people get opiates in pain in America? Because it keeps you going to the doctor's office, because we don't got much else. You know, anti-inflammatories are over the counter, and so is Tylenol. But the doctors really, think, well, you came to the doctor, you might get something, need something that does something. But I'll tell you, not just because you don't have anything else doesn't mean it's a good idea. If all you had was dynamite to rake the leaves, okay, this would not be a good idea to keep throwing dynamite until the leaves kind of go into the right direction. It's a bad idea, but it seems to be for a lot of doctors, their thought that that's all they have. And for primary care, that may be all that they're trained to do. Not only is there a significant limitation in the treatment for addiction, but how to treat pain is very limited. I think I learned just as little about treating pain in medical school as I did about treating addiction. So again, with opiates and a number of those related medications, they work on the brain, but not where the source of pain is, and actually working on the source tends to improve the outcome. There are a lot of drugs that are really effective in treating pain, but again, for many people, they just look at it as this isn't going to work. But if you understood the science behind how non-steroidal anti-inflammatories and Tylenol work without the central nervous system effects, you get really phenomenal pain relief for people, but it's a psychological thing that has to be overcome often. So again, the use of opiate pain medications, including tramadol, can lead to cravings for alcohol and opiate medications and other drugs in these patients, and that's why it is important. This could happen. A person I know in recovery who's in the treatment field, he is a physician. He's been sober. He was sober about 40 years when he had bypass surgery and got Tylenol number 3. And after all that period of time, he knew it was happening after about 3 months that he became thoroughly addicted to codeine. And it doesn't matter how long you've been sober. Sometimes it may not matter what kind of program you're working. And many patients who are opiate dependent, who have been exposed to opiates as a result of minor surgeries or even major surgeries, say that the craving and the mental anguish that they went through around that opiate pain medicine was far worse than the pain itself. And I've heard that so many times that I have to believe that it's true. So again, non-steroidal anti-inflammatories, ice, there's all kinds of things that you can do to help reduce pain. In my practice, I treat a lot of patients with pain, a lot of people who have addiction, a lot of people with pain and addiction. And one of the drugs that we use in certain cases is called buprenorphine, or the drug in Suboxone. That does not mean it is absolutely safe for people who have addiction. In fact, there is abuse of buprenorphine if it's not controlled appropriately, if you're not watching the person. In the wrong person, it's a bad idea. But it can be beneficial in certain circumstances. Okay, enough about pain. We're going to talk a little bit about anxiety. For those people who are in recovery, think about the first 4 weeks in recovery. How many people felt a little anxious, perhaps? Raise your hand. Okay, so most people, I think, who are in early recovery. It is almost universal, and I think that just is simply trying to deal with the life on life's terms without the tools yet to manage it. Most people in early recovery do not have a really good social network when they get here. They don't claim to have good friends, or they had to get rid of a lot of associates. They feel very alone. They have a resistance because of anxiety sometimes to doing 12-step recovery meetings, but it goes away over time, almost universally. And every person that I know now who is sober 10, 20, 30 some years felt very anxious in the very beginning. So it generally does not need a treatment the way we think it, the way a lot of doctors and psychiatrists might think. There probably is a small percentage. I don't know if 2 to 5% is really appropriate now. There might be some information that it's maybe even lower, that some people have generalized anxiety disorder that needs some sort of treatment. By the way, this doesn't mean they need Valium and Klonopin and alcohol, that they need appropriate treatment by a psychiatrist. The sedatives like Xanax and Klonopin and Ativan produce extreme cravings, especially for people who have had alcohol problems. And it really sets up for a feeling of relapse and during the feelings of withdrawal. I'm not going to go into them, but there are many safe and appropriate treatments for anxiety that are not addictive, that should be prescribed by a psychiatrist if you're that 2 to 5% of people who have anxiety in recovery. But also keep in mind, if one of the drugs that was being used by that person is a powerful sedative, like Valium or Xanax or Klonopin, sometimes that withdrawal for 6 to 9 months is indistinguishable from anxiety. You just feel anxious for a year, and it will go away. Insomnia, I think, is almost universal in people in recovery, with the exception of people who are coming off solely crack and amphetamines who will go to sleep for 2 weeks. But for a lot of people who are using alcohol, sedatives, and opiates, that normal sleep center is disrupted, and it's very, very common that they have insomnia. It almost universally improves over time. Almost universally, for some reason, people in recovery, if they cannot sleep one night, think they're going to die. It doesn't happen. People don't die from lack of sleep. They eventually sleep, and they will be okay. But it's often something that's important to talk people through. And the type of sleep is different, and it might be shorter for a period of time, but it eventually normalizes, usually 3 to 6 months after someone is recovered. Most of the common sleeping medications can activate the addiction center. And again, sometimes it's so severe that this would require assessment by a psychiatrist. The things I look for as a treating professional when it's time to think about a medication at all in somebody who is having insomnia is when it's persistent, it's interfering with their job, their other responsibilities, if it's interfering with their ability to participate in their recovery. That is when it starts to make sense that they might need something. But for the most part, they shouldn't be on any medications. And again, many doctors still believe that even now, maybe it's less so now, that drugs like Ambien or Lunesta or Sonata, if anyone heard of those drugs or some of them, that they were marketed as non-addictive, non-benzodiazepines. They were in that same category as Quaaludes. You know, we thought they were told they were safe, and they were not. Melatonin, however, which is a natural supplement, I have found for many patients to be very effective. Again, you should talk to your doctor about starting anything, even a natural supplement, before you do, which means you got to get a doctor. Depression, again, is this feeling of sadness and loss often. People confuse it with true depression. They just have this sadness and feeling of loss and the lack of motivation. And their life seems very different when they get sober than when they were out there. But it often resolves quickly with increased social interaction, 12-step recovery being kind of the mainstay for many people. Again, if it persists and interferes with quality of life, that's a person who would need to go to a psychiatrist to be assessed. But generally, medications are often not needed. In fact, some of the cases that got me very interested in this topic were patients who went to the psychiatrist saying they were depressed and anxious and got drugs that led to an immediate relapse. And in at least one case I can think of, a very quick death. So some people might say, well, you know, I'm an alcoholic, so the opiates shouldn't bother me, and, you know, or I just use crack cocaine, so, you know, I guess a sedative shouldn't be a problem. The way remember that chart shows that all those drugs activate the same center. So there may not be a drug of choice like we think, or a drug of no choice like we think. You know, it could be that any substance that activates the center leads to a craving. The craving eventually becomes the drug that the person has imprinted on. One person in recovery was talking at a meeting about the shark cake example of the drug of choice, and he said it's kind of like, you know, you know, there's your shark tank below you, and you jump off the diving board into the pool of sharks, and the shark's coming right at you, and you say, nope, you're not my shark of choice. At that point, it's too late. You know, you're in trouble. So the book of Alcoholics Anonymous, which was written somewhere between 1935 and 1939, or over that period of time, actually describes this process that you learned about. The neurobiology that you learned tonight was only really elucidated probably within the last 10 or 15 years. But over 80 years ago, this was written in the text and kind of explains the same exact thing. It says that the fact is that most alcoholics, for reasons yet obscure, have lost the power of choice in drink. Our so-called willpower becomes practically non-existent. Remember the logic center being manipulated by the addiction center. We are unable at certain times to bring into our consciousness with sufficient force the memory. Remember, the memory center is affected. We know that by the neuronal connections. And suffering and humiliation. So the feeling, the amygdala center, is modulated. So he's just, right here, we're hearing a description of how, when the addiction center is activated, how all these things change. So again, we are unable at certain times to bring into our consciousness with sufficient force the memory of the suffering and humiliation of even a week or a month ago. We are without defense against the first drink. So what do you do now? Again, you've learned enough to be very careful to understand that most physicians do not know hardly anything about addiction, and you may know a lot more now. It may help if you have the opportunity to consult someone who's certified in addiction medicine, who knows this topic, and I'm not the only one who knows this stuff. And if you have one of these doctors in sort of your team of caregivers, to give that person a call when you get a prescription from one of the other doctors, just to see if it's okay to take. That can be a very effective approach in saving yourself from exposure. However, it's probably not a good idea to get specific advice from the sponsor or recovery supports about your medical care, because there's a lot of, just as there is stigma about addiction in the larger world, there's stigma about medical care, you know, in the recovery community. So I think it's important to realize that Alcoholics Anonymous as a whole has no opinion on outside issues, meaning if you get an opinion from your sponsor or your recovery support, it may not be an opinion that you have to trust 100%, especially if they say this drug is okay or you should stop this medication, because there have been cases of people stopping life-saving medications as a result of something their sponsor told them, and there was some horrible outcomes. Okay, that leaves 15 minutes for Q&A. Matt, get up here. Don't. I like it when you stand next to me and they ask me all the questions. I like that part. Yeah.
I'm not a doctor, but I'm happy to answer any questions that would like to mention.
Anxiety in addiction, I should have said. That was a typo, it said is. Yeah, sorry about that. So the question is it okay to use drugs in sort of I'll kind of give it away when I say it's medically supervised detox? And the answer is yes, because in that circumstance, the drugs are usually used to stabilize someone medically when they're in a place where they're not going to get away, they're not going to overuse what they just got, and it'll be very carefully monitored. Often those doctors have some training in addiction medicine to understand what to do. And for instance, reducing the risk for seizure, for instance, in a person who's coming off alcohol or sedatives is critically important. There is maybe some controversy about reducing opiate withdrawal symptoms in patients coming off opiates. Some might even say it's better for them to go through that, but there's a lot of controversy with that. So the question is, what are my thoughts about trazodone, Atarax, and Seroquel? And the answer is, talk to your doctor in general. I wouldn't, in terms of what they're for various things in general for people in recovery. They're not particularly unsafe, but anything could be. It all depends on what they're being used for and the risk and benefits in that particular individual. Yes, sir.
Kevin McCauley is a guy who has spoken here at the Dawn Farm Ed series. He has some recovery management information that can be helpful for lay people to read and set up. I mean, you can, the Jays have this structured family recovery, which is also a guide to having the family be a support system. So I think there are people working on ways to do that. Bill White has written about recovery management, and so you can cobble together that kind of support in various ways. And I think the recovery community is key to all of that. Keeping people involved with the recovery community.
So what I heard you say is, what's the best way to help protect your client from the medical profession who might prescribe medications for them?
First 9 months.
Yeah, I think you have to make the client, the patient, their own advocate to understand that the medications are not going to help them in the long term. There's going to be a talk coming up in a few weeks. Jerry Fouché is going to talk about methods, non-pharmacologic methods for helping to induce sleep and reducing anxiety that can be used by anybody, and just reassuring the person that they're going to be okay eventually. And I run into that often in my patients, and a lot of what I do is just reassuring them that I care about them, I'm going to take care of them, they're not going to die from their insomnia. And I don't know if you're familiar with motivational interviewing, but you probably are, but to kind of grab onto, so how long did you sleep? And they say, oh, I only slept for 2 hours. They say, oh, wow, last week you said it was 1 hour. We're really heading in the right direction. Kind of encouraging someone to kind of take note that they're improving slowly, and they might need help to do that.
And the sleep hygiene stuff is really important. I mean, I work with people all the time who I can't sleep, but they're drinking 5 monsters a day, taking naps half the day, waking up at different hours every day, going to sleep at different times every night, eating a bunch of food at midnight, so all that kind of stuff, not exercising. I mean, there's tons of ways to address this behaviorally that can be helpful.
And they work, they do work. Yes. So the question is, what's the difference between dependence and addiction? So dependence is a physical thing that occurs, we're talking about chemical dependence, is a physical thing that occurs in all people if they're exposed to a certain group of chemicals that leads to dependency. And it could be a number of things. Opiates can cause dependency if gradually increased long enough in anybody, such that when you stopped it suddenly, the person will experience withdrawal, which is a set of physical symptoms. A lot of drugs, a lot of antidepressants do this, gabapentin does this, Lyrica does this. There's a long list of drugs that do that. However, that is different from exposure to a drug altering behavior. When behavior is altered, priorities are altered, a whole lot of things occur that are not just dependence related. That is addiction. Addiction involves the continuation of doing behaviors that ultimately lead to harm. And those behaviors and the harm is very obvious to the outside observer, but not very obvious to the person who has the addiction at that time. And they actually work on, there are different centers of the brain that, like the addictions, we talked about the pleasure center is involved in the addictive behavior. There's a completely different part of the brain that's involved in the whole dependency and withdrawal symptoms. Yes?
I think we expect too much from primary care doctors these days.
Right, exactly.
That's the first line of defense, and we're sending everyone, we sort of expect that primary care doctors can treat everything, and they can't.
Yeah, and my comment to the question of, I'm trying to restate that question, which would be, what's the difference between how you receive the drug if you're the patient, whether it's a psychiatrist or an addiction, right? So, and that's and what are the guidelines for that? So there really aren't any good guidelines, and if there aren't any good guidelines, nobody follows them. But the problem therein lies that it's not about the drug, and it's not about the doctor, it's about the patient, because that changes everything. And so the attention has to be on the patients. When the attention is on anything else, things go wrong. things just go haywire. So what I always do when I train doctors is focus back on what is best for your individual patient in that specific circumstance, irregardless of guidelines, the DEA, lawyers, the insurance company, or whatever, and then fight for that, for your patient to get the best care. Yes. So the question, just to restate it, is what is the best treatment for PTSD in addiction, let's say, right? Well, my opinion on that, and I've treated a lot of patients with early life trauma and PTSD who later go on to develop both addiction and or chronic pain, and I can tell you that there really is, in my opinion, no good drug for treating PTSD. There is a lot of really good therapy for treating PTSD, and it requires a lot of engagement and working with a therapist who specializes in dealing with unresolved grief and loss and trauma, and those are the patients that I see doing the best. They're the ones who are doing fabulously. There are medications that can treat some of the symptoms around that a psychiatrist can give, but they're not going to be, patients with PTSD do not benefit from things necessarily that are sedative. They really need to do the therapy. And that's just the experience based on the patients that I've treated. Yes, sir. So again, it all depends on the patient. Is Trintellix good or bad? And it all depends on the patient and their specific needs and the risks and benefits in that particular. Any particular drug can be good or bad depending on the particular patient. So I don't have a specific broad view on the drug itself. So interesting question. So the question is, what about Narcan, and does it increase craving for alcohol and opiates? And so from a medical standpoint, no, it doesn't do that at all. Naloxone or Narcan is an opiate reversal agent, and all it does, or what it does, is it binds to opiate receptors, kicks off the opiate that's there, whether it's morphine or heroin, and allows a person to be revived. And it's short acting, it disappears in sometimes 20 minutes to an hour, but it can be very important, and I do not think that people are prescribing enough of it, because it should be out in a lot more situations so more people have access to it. A lot of law enforcement do. I mean, I think schools should have it. They have all those defibrillators around, people, and we're not having an arrhythmia epidemic, and we got defibrillators in every mall, but we should have, we have an opiate overdose epidemic. We should have Narcan in more places, in my opinion. So buprenorphine, we talked about it a little bit again, it's all about the patient. So the drug itself isn't good or bad, depends on how it's used and who it's used in. And so buprenorphine can be very effective at stabilizing people who are in opiate withdrawal to engage them in a recovery system. That's what I think its main role should be. It is not, in my opinion, a treatment for addiction at all. I think it is a treatment for withdrawal, because it reverses withdrawal. Without a recovery system, it doesn't work all that well. In therapy and some sort of, whatever the recovery is, whether it includes therapy or psychiatric treatment or 12-step recovery, but it's got to be part of a bigger system for it to be of benefit.
Yeah, I don't have anything on the top of my head about sleep hygiene. There was a guy on NPR last week who I thought hit the nail on the head. He was man, I can't remember where he was from. I mean, the sleep hygiene stuff is really simple behavioral stuff, and but I don't know, I'm sure Jerry will talk about it in a couple weeks. I don't know any specific resources off the top of my head. If you have a person in recovery who's having a hard time sleeping, tell them to read the big book.
Good answer. That's a good answer.